Thank you for joining us for this learning series webinar, The Opioid Epidemic, a focus on vulnerable populations. This is the second webinar in this learning series addressing this important topic, and I thank you for joining us today for this conversation. Today's webinar is brought to you by the Partnership for a Drug-Free New Jersey and is being held in collaboration with NJCRCs and the New Jersey Office of the Attorney General, and I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. As Greg mentioned, information on continuing education credits will be shared in the chat and at the end of today's presentation. Also, a copy of the slides and a recording of this presentation will be made available to all of our attendees. I'm so pleased to introduce our featured expert speakers who are with us today. We have the Honorable James E. McGreevy, Executive Director at New Jersey Reentry Corporation, Barrett Young, the CEO of Rescue Mission of Trenton, and Brian McGovern, Chief Executive Director of the New Jersey Community Research Initiative. Thank you to all of our panelists for joining us. I appreciate you taking the time to share your expertise and perspectives with us today. And I will now turn the presentation over to Governor McGreevy to kick us off. Welcome, Governor.
Thank you so much, Angela. I appreciate this opportunity. And I want to thank you and particularly Matt and the Attorney General's office. So thank you very much for this opportunity. I'm here on behalf of the New Jersey Reentry Corporation. And the first thing that I would like to do is to underscore our commitment working cooperatively with the administration and the state legislature to provide for immediate access to treatment. So you'll see on the first graphic on your screen that NJRC is committed to clinically appropriate treatment, whether detoxification, residential treatment, IOP, induction of MAT within 24 hours enrollment. And at the bottom of that, you see Robert Carter's name and phone number. And what's so critically important is that our commitment to the state legislature, our commitment to the governor's office is that we enroll people effectively within 24 hours. Next slide. The New Jersey Reentry Corporation embarked upon a report entitled A Modern Plague, and this was done in an effort to secure best practices. And I would just ask anyone who's interested that they would be able to access our website at www.njreentry, that's NJREENTRY.org. If I can publicly recognize Susan Kunis from Blue Cross Blue Shield, Shatterproof, and Katie Forkey of Yale University School of Law for their hard work in identifying best practices. If I can, what I'd like to underscore at this moment is that not only the significant number of drug overdose fatalities that occur in the nation, as we have surpassed 100,000, but understanding the scope unique within the state of New Jersey. For our population in New Jersey, we have 14,868 clients, and our rearrest rate is approximately 19.7, while our reincarceration rate is 10%. What's important to note is of those 14,868, we have over close to 9,000 enrolled in addiction treatment, as well as medication-assisted treatment, and we have over 4,000 enrolled in psychiatric treatment. What we see is with the advent of the opioid crisis and dual diagnosis, the necessity to provide for both psychiatric as well as addiction treatment care. And if I could emphasize what's so critically important to the population with whom I have the privilege of working is that the risk of overdose death for the previously incarcerated is approximately 130 times greater than that of the general population. And if I could underscore this point, is that many reentry clients die within weeks of rejoining the community. And we all understand the advent of synthetic opioids such as fentanyl and ISO, not only have increased or the penetration of the heroin supply. In fact, in many urban communities in the state have actually replaced the heroin supply. But coupled with obstacles such as food insecurity, housing instability, legal challenges, poverty, and unemployment, that the cravings are frequently very high among those that are reentering the community, but their resistance is quite low. And so what we like to, the first point is, as New Jersey is facing some of the least expensive, whether it's high purity street heroin or fentanyl, what we need to understand is that this population is tragically more susceptible to overdose deaths. Leaving aside the neurobiology of opioid use disorder, what we see is what we're very much mindful of, and can we go to the next slide, is the fact that this is back in 2017, and we've all seen the recent graphs from the New York Times, is that 115 die of an opioid overdose every day. This was as of 2017. Next slide. And so what we understand is there's not only the cost to the tragic loss of life, but how the opioid epidemic faces or confronts a wide breadth of American society. The first is the impact on the criminal justice system. Itself is upwards of $217 million per year, not including arrests and adjudication costs. We also see the total cost of direct medical costs to opioid overdose events exceeding $633 million. And lastly, a loss of productivity in the sense that those individuals are not productively engaged in the workforce of over $1.2 billion, likely a low estimate. Next slide. So what we believe in the New Jersey Reentry Corporation is in accordance with the national principles of care for addiction treatment. And this is what we try to do in terms of New Jersey Reentry. All individuals coming within any of our 10 reentry sites, that there's universal screening for substance use. And so that the individual social workers provide for a basic biopsychosocial background. You'll see number 2, rapid access to appropriate substance use disorder. Both we have partnerships, whether it's with Rutgers Medical School, with Newbridge, as well as numerous certified community behavioral health care centers, as well as the FQHCs. And during the course of COVID, literally 3 times a day at each of our sites, we had the opportunity, the advent for telehealth, where individuals were able to work cooperatively with doctors and be inducted on MAT through Newbridge. So if I can just recognize Newbridge for their outstanding partnership. Why that Newbridge was so important, and there were numerous treatment providers with whom we also work with, literally throughout the entirety of the length and breadth of New Jersey. But why Newbridge was so important, I want to express my gratitude to the administration for their bold steps with presumptive Medicaid eligibility. But it's also even being mindful of presumptive Medicaid eligibility. There were those cases where individuals would not be able to access Medicaid. And such, it was important that it be an acute care facility as opposed to a treatment provider to access necessary dollars, what's historically known as charity care. Third, you'll see a personalized diagnosis, assessment, and treatment planning. What we do at New Jersey Reentry is mindful of our population. We provide for a diagnosis and assessment, both in terms of behavioral needs, whether that's psych, addiction treatment, and the full array of courses, as well as medical. The old way of doing reentry, simply put, you would secure someone a job, an employment opportunity, and if they survived for 60 days, let alone 6 months or 6 years, it was something approaching a minor miracle. What we try to do at New Jersey Reentry is working with our healthcare navigators who work directly with our client population and our social workers is to provide for a rational diagnosis, an assessment modality, that assessment plan that we think is rational. If I can, sometimes the tension, and I'm sorry, I just can't answer questions in the chat as I'm doing this, but I'll be glad to do it afterwards. So thanks, Robert. The challenges for our clients, just bluntly, is sometimes the tension between providing for treatment while they're literally trying to provide for work and employment opportunities. And so for so many of our clients, when they come out into the community, they are challenged to immediately grapple with whether it's outstanding fines, warrants, and our legal staff does a great job. But we put a priority on treatment as a first requirement. If you look to number 4, engagement and continuing long-term outpatient with monitoring and adjustments to treatment, what we try to do is to make sure that that person has a continuum of care. Our preferred goal is for 18 months, whether that's no longer IOP, but that's continuing to be seen by our social workers, continuing to be seen by the treatment provider, and obviously continue to be seen by the psych. Number 5, if you could, concurrent coordinated care for physical and mental illness. One of the great challenges is not only something as mundane as securing an ID, which for our clients, many of which are coming from NJDOC facilities, they may only have their Department of Corrections ID. They have to secure their birth certificate. They have to now secure their Social Security card. It can no longer be a Xerox copy. The integrity of the document is critically important, as well as the other 2 points to secure an ID. And just be mindful of the fact that an ID is essential for Medicaid, and that can take in and of itself upwards of 30 days. So we're mindful of the fact that while we immediately provide for MAT, we immediately provide for access through our CCBHCs and FQHCs for addiction and psych, sometimes unfortunately grappling with everything from hepatitis C, which is all too common in our population, to diabetes, a small percentage of HIV. That Medicaid card is critically important. So we have our social workers, I can't say thank you enough, and our clinical director, who's outstanding. She's a past member of the Board of Social Work, Suzanne Herman. But what we believe is so critically important is, if I can move to number 6, is access to fully trained and accredited behavioral health professionals. I'd like to thank Dr. Gloria Bachman, who's our medical director. Gloria is a full professor at RWJ Medical School. She's outstanding. She also works directly with a woman at Edna Mahan, and our healthcare nurse navigator, a trained addiction treatment and, a psych nurse, Constance Kersey. So what we like to believe is, with our relationships with Rutgers Medical School, with our relationships with acute care facilities, CCBHCs, FQHCs, that we are providing access to the best trained behavioral health professionals. On a localized basis, we also have partnerships, say, for example, in Newark with Newark Beth Israel, in New Brunswick with RWJ Hospital, so that we also have partnerships on a regional basis. As an aside, and I don't want to get too far afield, we also have what we call circles of care, where, say, for example, for the women, for individuals who want to have ongoing discussion groups, that they can be ongoing discussion groups led by an MD on a wide variety of issues that are important. Everything from addiction to, for the women, obviously, OBGYN, to behavioral health issues, housing, etc. So we believe very strongly in having the best medical physicians as part and parcel of our commitment, and I can go through the people: Petros Lavonis, Chair of Psychiatry at Rutgers; Dr. Erin Zerbo at Rutgers; Caitlin Bastone at Cooper; Louis Baxter, Professional Assistance Program; Dr. Joe Ranieri, and many others who are part of, and Chris Purnell at University Hospital, my dear beloved friend. So we work closely with a team of physicians on an ongoing basis to make sure that we are providing the best access to not only accredited behavioral healthcare professionals, but as important, as critical as that is the integration of healthcare, whether it's psych, addiction, and medical, which is so often difficult. If I can jump to number 7, FDA approved medications is obviously so important. And one of the things that University Health has done within the prisons, and we're very grateful, is to expand the opportunity for medication-assisted treatment, specifically Suboxone. But just bluntly, one of the real challenges is that presently, and I can't thank Commissioner Designate Victoria Kuhn often enough for the closer coordination than in years past between NJDOC and NJRC, for which I am profoundly grateful. But one of the real challenges is to ensure that NJDOC gives clients at least a month script of medication-assisted treatment. The real challenges during the course of COVID, during the course of the pandemic, when challenges with whether dealing with DOH, dealing with MVC, with any entity, and the boards of social services were so much more onerous just because of contact. But we believe that FDA approved medications need to be provided for at least a month long upon exiting prison, especially for those persons who don't have an MVC ID and are not going to be able to immediately secure Medicaid and thus be able to have a means of financing or paying for their individual prescription. So again, access to FDA approved medications is a cornerstone of what we do. Obviously, considering the fact that many of our clients have co-occurring mental health and addiction challenges, whether it's gabapentin, Effexor, Seroquel, and their MAT, what we need is essential is access to Medicaid and physicians that accept Medicaid as payment in full. But that's so important. Lastly, number 8 is access to non-medical recovery support services. This is, our bread and butter. And again, if you want to go to our website, www.njrentry.org, you'll see our annual reports for every year and individual reports on a wide variety of areas. But when we talk about non-medical recovery support services, we're also discussing the importance of structured sober housing. We're also working with our legal team, and I can't thank enough our general counsel, Rahat Chadha, Damon Watson, who presides over our legal points of contact, to make sure that we address outstanding warrants, fines, so that people can move towards having an MVC ID and eventually a driver's license where appropriate. In addition to all of those services, obviously we have something called the Governor's Reentry Training and Employment Center that's in Kearney, New Jersey. It's a 25,000 square foot facility where we provide for training on everything from peer recovery, which is so incredibly rewarding, seeing individuals who have historically grappled with opioid use disorder now to become in the business of peer recovery, and working with hospitals and working with facilities that are in the business of addiction treatment throughout the state of New Jersey. But we also provide for Cisco certification and networking and routing. We're about to embark upon a partnership with Apple, but we also work with HVAC, with welding, with CDL, and a wide variety of courses. So when I say access to non-medical recovery support services, Obviously, that's what we understand to be the traditional reentry responsibilities, whether that's first medical, second legal, then housing, then training and employment, and ongoing mentorship. Next slide. So this is where we're at, and I don't want to be abusive of my time, but basically what this is our goal. And so this is, if you will, and I want to be respectful, and I want to thank both the Knockout Opioid Abuse Day and Angela and everything that Matt and Brian and then Barrett is going to share with afterward. But if I can just go through this, is one is MAT-based treatment. MAT is so critically important. And we ensure that all medication types are available, but that's so critically important for NJRC. We have people that have been on MAT for 5 years plus. Our goal is to titrate to a lower dosage, but we work and it's clinically driven. Second is you'll see continuity of care. And I'm sorry to go through this so quickly, but on MAT, under the MAT slide, if you can, under number 1, you'll see receive MAT, all medication types available. Underneath that slide, you'll see enroll in residential, standard outpatient, intensive outpatient, or detox. And then lastly, receive addiction therapy and counseling. So that's key for the start. Number 2 is continuity of care, is that receive a personalized treatment plan, maintenance treatment, and addiction counseling as needed. And that's also working with our nurse navigators, working with our case managers, doctor's appointments, peer-based therapy, housing, employment, food assistance, and you'll see the NJRC logo, wraparound services. And I can talk about how we've used apps, and we had a great partnership with the New Jersey State Parole Board on a swift, certain, and fair grant with USDOJ. But I just want to be respectful of everyone's time. Number 4, health information exchange. So this is what we do here in NJRC is have exchange information. And one of the great advantages is of having 10 sites is that if Jim McGreevy comes out of Northern State Prison and I'm in our Newark site, and then we transfer to our Ocean County site, we have a central database through Salesforce that we can provide for information as to addiction treatments, standard of care, and integrated efforts to provide efforts which would hopefully augur for our effectiveness. But what we long for is to have a state health information exchange, but we've incorporated a health information exchange as a best practice internally with NJRC. And you'll see underneath that, under information is released to service providers as needed. Number 5 is peer support, recovery coaching. Obviously, we train people at our reentry training center for peer support workers who have themselves experienced recovery process, provided support, engagements, and guidance for persons seeking treatment for opioid use disorder. And 6 is evaluation. Data. Again, we use Salesforce and we work cooperatively with our providers. So this data is gathered throughout the program from each of the participants' intakes and to 5 years post-completion. And I think that's the end. So with that, I just want to say thank you to Angela. I want to say thank you to your patience and listening to me. I think I went well beyond my time, and I will turn it back over to Angela. Thank you, Angela.
Thank you, Governor. Barrett, I will turn the presentation now over to you.
Thank you very much, Angela. Thank you, Governor McGreevy, for what you just presented, and I look forward to hearing from Brian as well. Just real quickly, I wanted to just thank everyone for having me today. It's an honor to be on this panel with such distinguished other panelists. And I'm hoping that the folks out there on this webinar learn something from this presentation today. Quickly, The rescue mission has an array of services that we offer to our community. I like to look at us as we are really the full continuum of care for any and all clients that come to our door. We are most known in the Trenton community for our emergency shelter, which operates 365 days a year, 24 hours a day. We also have a behavioral health unit, residential, which we are a licensed substance use treatment provider for. We have 91 beds in that unit. We also have an ambulatory unit where we offer outpatient and intensive outpatient services for substance use. We have a permanent supportive housing unit, which has about 45 units of housing in it. We also have 2 community sober living residents. We operate a thrift store here in Trenton, which has become a huge community need, especially during this pandemic. And speaking of that, during the pandemic, we realized that our customer base in our store was struggling mightily to put food on their table for their families. So during the pandemic, we began to operate a food pantry. Lastly, any of this information or anything that you wanted to look into further, you could go to the Rescue Mission of Trenton's website, which is the rescuemissionoftrenton.org. Next slide, please. So quickly, I'm just going to look at a couple numbers that we have in our residential, and then the next slide we'll talk about our shelter. But we're going to look at the kind of the stigma around both substance use and mental health in the clientele that the rescue mission serves. As you can see here, in the calendar year of 2021, in our residential unit, we had 339 intakes into the unit, and at intake, 0 of our clients reported having a mental health issue. 334 of them reported a substance use, and 5 reported both. Outside of that, 120 of our 339 clients that came in went to outside services for mental health. So that there speaks to the fact that our clients are in need of mental health services, but they just are afraid to ask for it. And the big thing that I think has become apparent in our industry is what has come first, the mental health or the substance use disorder. And the clients really struggle with asking for help if they have the mental health, and then they lead to substances, which leads to further down the road, which leads to opiate use, and ultimately death, as Governor McGreevy spoke about how deadly this disease, the disease of addiction is, but especially when someone gets addicted to opiates. And then the last thing for our residential is, of the 339 intakes, we had 136 of our clients received MAT services for Suboxone or methadone. And I think that Governor McGreevy touched on this nicely, is MAT is such a wonderful tool in our tool chest to try to begin the recovery process for our clients. If you can get a client on MAT and get them to focus on themselves and their recovery instead of focusing on getting high, it opens the door for so many potential avenues to help. Next slide, please. And then in our shelter for the calendar year of 2021, we had 720 unique individuals enter our shelter. That means that is either they came in one time or they came in 365 days. We only count them once they come in the door. We do not count them as a repeat, a customer. And again, these are all self-reported numbers. You can see here, 158 reported mental health, 109 substance use, and 100 reporting both, for a total of 367 reporting one or both of the biggest issues that drive people off of the, out of their house and onto the streets. So about 50% of the clients walking into our shelter are reporting that, but we see almost every single client who walks into our shelter suffers from one of the two, if not both. And it makes it very difficult to begin to help someone when they're not willing to accept or even believe that they have one of the issues, mental health or substance use. In our shelter, we have 6 case managers who work very closely with trying to link clients to both housing and treatment. Treatment could be going into inpatient, treatment could be going down the street to get MAT, treatment could be going across the street to the federally qualified health clinic to get primary care and MAT. We do a ton of linkage to services. We work very diligently on trying to help the clients obtain their documentation, the license, or excuse me, a identification, birth certificate, and social security card. And those items were hard to receive and obtain before the pandemic. They're now even more difficult for our clients. So that makes the opportunity to get into housing even harder for some of our clients. The one thing I just wanted to quickly highlight is both during the pandemic in 2020 and calendar year 2021, we were able to house over 100 clients each year out of our shelter. And that is a testament to the hard work that our case managers in our shelter do to link them to housing, but also to link them to those services so that the client can stabilize before leaving our shelter. The other thing I want to highlight here is the last thing there is the number of Narcan saves. That is the number of Narcan saves that we had in our shelter. That in calendar year 2021 we had 19, and that's 19 different times we had to administer. And as a lot of us know, the potency of the heroin on the street, especially with the fentanyl, the carfentanil, the norfentanyl, the potency has become increasingly even more and more dangerous. So those Narcan saves are becoming, unfortunately, you need to use 2, 3, 4 Narcans in those instances. And it is a very scary situation for both our clients and for our staff. But our staff are admirable in the way that they deal with the clients, and they deal with the situations that they're faced with day in and day out in our shelter. And then the last slide, or next slide, please, which is my last slide, but I wanted to just quickly touch on this. This is a new endeavor that the Rescue Mission is beginning on working with, which is a partnership between Mercer County and some community partners that the Rescue Mission has partnered with: Catholic Charities, Iron Wellness, Henry J. Austin, just to name a few of our partners in this. Is we will begin to have a mobile outreach van go out on the street, and the primary goal of this outreach van is to have a peer recovery specialist on the van who will go out and try to engage individuals who are struggling with addiction and or their loved ones. We will take this van out. We will park it in known hotspot locations. And the premise of this is to try to develop trust with those individuals, and, as I said, engage them into getting into some sort of treatment. Is it they go to Iron or Henry J. Austin to get MAT? Where do we meet their needs, and how do we meet their needs? This van will be outfitted with Wi-Fi capabilities, so that if a client comes up and has a abscess on their leg and they want to get it looked at, but it doesn't need to go to the emergency room, we will have the capability of getting them linked with a telemed right there and then right at the van. On the van, just to name a few things that we will offer, is obviously we would offer the individual to come to the Rescue Mission shelter if they're in need of shelter. We will be giving out food. We will have Narcan. We will give out education packets, which will include potential COVID rapid testing for the clients, where they can go to get a vaccine, information about our partners in the Rescue Mission, And again, just on that van, we will try to provide the full array of case management services. What does the client need right then and there? And we're going to try to link them to that, because again, the premise of this is to try to get that individual off the street, off of their drug of choice, and into some sort of treatment where they can begin to rebuild their life. And the key to that, that I would believe in wholeheartedly, is without trust and without that level of support, it is very hard for folks to get involved in that, because if they don't believe what you're saying to them, they're not going to come back. And because so many of our clients for so long have been told no, or been told that they aren't good enough, or been told, oh yeah, I'll get that for you, but I'll get it for you in a minute. And then no one ever goes back to that and takes that offer to become true. So the clients are just hurt. And this whole premise is we're not about that. This is about getting you the services that you need right then and there, and linking you to the services. This is a new endeavor for us. I'm very excited about it, and I think it's cutting edge. I'm looking forward to this and seeing where it goes. And with that, I will turn it back over to you, Angela, and thank you all.
And I think it's just important to note that Barrett is part of the greatest family, and one of the greatest families in Trenton, with Mary Gay. So one of my patron saints. So I just wanted to underscore that.
I appreciate it, Governor. I didn't want to get into any of that because you had taken so much of everyone's time already. So thank
you. Your mother set the standard for all of us.
Thank you, sir.
And God bless her. Thank you.
Well, thank you, Barrett, and thank you, Governor, for giving us a little bit of background. I'll now turn the presentation over to you, Brian.
Great. Thank you. Hi, I'm Brian McGovern. I'm the CEO of NJCRI, and we're here in Newark, New Jersey. I've been here for about 22 years, first as a social service director, and then moved into the CEO position. A few things just about the organization real quick is we really provide, the agency was first born as an HIV/AIDS organization, focusing on research, trying to bring clinical trials back in the 1980s. When I got there, I had come from various hospital and community-based organizations, and I saw just a really diamond in the rough, and really a harm reduction agency without anyone really realizing what we were doing. So really that's been a focus of ours. And then trying to take that hospital structure and the community service piece into the community. So next slide, please. These are just some of the services we provide. There's a lot here, so I'm not going to go subject by subject, but our primary purpose is to have an attraction, build an attraction for the clientele, whoever that clientele is, to want to come. So it's not about our services, it's about why do they want to come, something they want. So just to point out a few, we have a homeless drop-in center that has washers and dryers and showers, a dry place, a warm place, a place to charge your phone, a place to rest, a place to use computers, look for jobs, so on and so forth. So those are some of the attractions. And to be honest, the washer and dryer and the showers are the main attraction. Then it's up to us to help people get into care, help people to get mental health, substance abuse, and medical care. We have a full-time nurse that works in this department. We have substance abuse counselors and social workers. So then it's up to us to really help them. And we have to do that with baby steps. There's also a needle exchange program in this drop-in center. So with all that said, that really helps with baby steps to try to bring people along. So one of the other things we do here is we have a pretty high adherence rate when we do test to treat. So what we do is we test and we treat as best we can in all areas. So we do have mobile medical units now. Sorry for the sirens in the background. But in our mobile units, we have nurse practitioners, nurses, community healthcare workers, social workers go out. Anything from a COVID diagnosis to Hep C, HIV, STIs, all done on site. In addition to that, we have a behavioral health team that will go out as well. We usually go to very high risk areas. We're out at 5 a.m. in the morning and we're out till 11 p.m. at night, very selected areas. And we find that this really took off, we've always done it, but really took off during COVID. So that's been a major impact. My primary today is to talk about the LGBT community. So when I talk about attraction, we're doing the same concept. What I talked about is more that traditional service model, but we also do this with the LGBT community. With the LGBT community, what we're doing is we're going out to, with a mobile unit or with our drop-in centers. Our drop-in centers, LGBT youth center that we've had for over 20 years, the attraction is the center that young people can come in and allow to be themselves as LGBT young people. Maybe they can't do that in their community, their school, or at home, but here they can. So their attraction is to a comfortable place, a welcoming place. We do regular dances for the kids once a week. We do many different activities. We do retreat activities as well with them. And then it's up to us again to help get them into different type of services they might need. We start with a prevention service where we just really look at what skills they might need to be more empowered and to have less harm reduction, or have to reduce their harm in the community. And with that, what we learned quickly is to add in a piece strictly around substance use, really from harm reduction substance use to harm to actually substance services. So some of the services, what we found is it's better to have outside the center for the kids' own privacy. So the center is actually in a building that serves all these services that you see: medical, substance use, and so on. So a young person in the youth center would meet with their youth counselor, would have a substance abuse counselor or another harm reduction counselor right in that center. If this person needed more severe treatment or services, they could move throughout the building from a medical or behavioral perspective. Some of the outreach that we would do is that we do these dances. In the LGBT center, we do a lot of voguing, very popular. And many of these Vogue dances that we sponsor also we can bring a medical unit there. We can do testing on site. And that has yield to a large percentage. So our outreach is roughly about, last year, I think it was 1,650, 750 youth served, 80 active members on different programs that we have, tested about 150. And sadly, we had about, well, just this year I'm going to talk about so far, we have 8 new positives. So and this is for HIV. So that number has really jumped up. To bring it over to the opiate perspective, many of our young people are brought to us either from our needle exchange program or from the homeless drop-in center, or they come in during intake and talk about their substance use. Next slide, please. So here, these are just some outside facts about percentages of alcohol use, marijuana use, and prescription drugs. What I want to focus in on, our youth center, 80% of our kids coming in during intake have talked about some type of drug use. So we're starting with a pretty high level of drug use in the center when we start. Many of our kids, 70% of our kids are actual homeless as well. So a lot of their substance use is around just dealing with some of the stressors and the traumas they have in life. The idea that they do not have a formal place to live. They're doing a lot of surf couching. This was hit very hard during the pandemic, as many of these kids would be living in other people's homes and asked to leave because they were an extra burden to the family that they were living with. So we had to do a lot of work on housing to get these people sadly into some of the shelter systems and so on and so forth. So next slide, please. So these are 3 areas of our LGBT services that are more the attraction. We have what we call the Project WOW Youth Center. As you can see, that's a picture of the drop-in center. We have a Pride Center. The Pride Center is really a place where our goal is to move our young people able to move into a more of an adult setting. And what we find is some of the higher risk groups is 24 to 30 of some of the high risk getting into more heavier drug use with some of our kids, also homelessness. So we have this Pride Center that really can continue to work with our little bit older population, and then also with our seniors and general population. So we're really excited about that. And then last, we just started a program with our trans population, which just has enormous lack of services and lack of treatment in this area. If you go back to, just to remember back at our service slides, we also have a trans clinic. So we do a lot of hormone therapy with that population and reassignment. So what we can do here is the attraction might be the hormone therapy clinic. However, from there, we can also do a lot of medical care, substance abuse care, and get them into other services. Again, I mentioned that we have a needle exchange program, and we also have a homeless drop-in center. So we can go to the next slide. So the homeless drop-in center, one of the things we do there is that we think, okay, serves a population off the street, so on and so forth, which many of our young people are, our LGBT community are. But we also want to recognize that sometimes our transgender population are not comfortable in such a setting. So where the drop-in center for the general population might be open from 7 a.m. till 5 p.m. After that, we have evening hours with the LGBT population, so they can also use the showers, washer and dryers, and feel a little more comfortable with another population. And then therefore are also introduced to the needle exchange program and so on. And in the general population of our homeless and the needle exchange program, during our intake population, we can also help connect some of our LGBT that go through there back into some of the LGBT services. So it's a back and forth approach. I think last, I just wanted to really mention, I think some of the new things we're working on in this area is we're working on a drop-in center for downtown Newark to work with Penn Station and with the city and with the police department to create a safer space for the homeless of Penn Station. In that, we will also put in a needle exchange program. They can also work with our MAT program that's in-house at NJCRI. And we will also bring down their medical care. So anything from health screenings to actual treatment of care. And that we plan to do hopefully a few blocks from Penn Station. In addition to that, I mentioned the medical units. Medical units, what we're really doing is we're going out to some of the high-risk areas. We also go to some of the high-risk needle exchange areas where needles are being left on the ground in communities, shooting galleries, and we're going there to help clean up the community. as well as introducing ourselves to people that may not know about our needle exchange program. And I will say our needle exchange program is probably most known through a website, really through word of mouth and through online communication. And last, all our services are, ability to pay. So we'll serve all people. And I just want to say, with everything that I've heard today, from housing to reentry programs, these are things that are very true and dear to NJCRI. And any way we can help the community and help bring down some of these numbers, we'd be excited to do. Thank you.
Thank you so much. Thank you to all of our speakers. I think the comments and the information that you shared has been so helpful. I know we're running short on time, so I have one question I'm going to ask. I'm going to bring it to all of you. I will start, Brian, with you, but also, if you could just share in that as well, any last thoughts you think are important for our audience to take with them. But could you explain why, like, what is at the heart of why the LGBTQ plus community and people experiencing homelessness and those formerly incarcerated are so vulnerable to opiate addiction and overdose?
Well, I think with I think Barry said it. I think Governor McGreevey said it. Is that our populations are so vulnerable to start with. I mean, they don't feel that they fit into their communities. They're struggling with their own personal trauma in the LGBT community, how to fit in, transgender populations. And I think as a result, is it an avenue of trying to treat their mental illness, or is it an avenue of try to reduce their stress and anxiety of the community they live in? I think some of those, I think their addiction level, I'm a person of 35 years in recovery. I think there is their ability of being, their piece of being addicted as part of their nature is probably there, but I think it's no more than the general population. I think it's add to it some of the other stresses they're going through.
All right, thanks. And Barrett, do you have anything to add, or from your perspective, can you speak to the question?
No, I think Brian handled it well. I think the hardest thing for the homeless is, just in regard in everything, is just that the stigma that, in whatever population you fall into and whatever demographic it is, LBGT, whatever it is the stigma. And I touched on it during my presentation, was the stigma that comes from being a homeless person. And then you add on, I'm an addict, I'm an LGBTQ, and it just exacerbates all of the issues that they have, and it makes it so much harder for them to accept or to want to get services, because the system for so long has told them they're not good enough. That I would add that piece.
Okay, and so Governor, thanks, Barrett, and Governor, I'll leave you with the last word, and also what can those in attendance, do to help eliminate some of these issues, or to help address some of these issues?
Well, I just also want to say thank you to Brian, selfishly, in terms of the community, and particularly in terms of LGBTQ youth and the challenges that they face. I mean, I think Barrett and Mary Gay or Brian or any of us would all say it's those that are vulnerable, those that are on the edges of society. But also the reality is that just in terms of opioid addiction, that was in many cases a crisis for the majority community, because so much of the opioid crisis originally was driving by access to prescription drugs, namely Percocets, oxycodone, pain, so that if you were if you were somebody who did not have access to a prescription drug benefit program, or do not have access to Medicaid. You know, many of the crisis of today's focus, the opioid epidemic, came originally from those that had prescription drugs and then would, you know, shop physicians, shop pharmacies. But then the tragedy is, you know, that we saw fentanyl as a synthetic opioid now literally ravage entire communities. And whereas originally the opioid use disorder crisis was around the majority community and overdose deaths, but what we see is they're growing rapidly within communities of color. So that while the onset of and you know, Brian and Barrett know this far better than me, but while the origins of the opioid use epidemic may have had its origins in the majority community, the tragedy of synthetic opioids is it's ravaging every community. And I would also just say, Ange, it's access to healthcare. I mean, if you're poor and you're Latino or you're African American or you're white and you don't, and your family's enrolled in Medicaid, or if you don't enrolled in family care and you don't have access to healthcare, whether it's detox, whether it's residential treatment, whether it's ongoing IOP, these are critical issues. And that's why it sounds corny, but the first thing I did is say that if you have somebody, you know, 732-948-5880, wherever they are, we'll make sure they're enrolled. We work with all sorts of treatment providers that will accept Medicaid, presumptive Medicaid eligibility. But to go to what Barrett said and go to what Brian said, who do this every day of their lives in meaningful on the ground ways, it's vulnerable populations that don't have support systems that are consistent, constant, and reliable. And so these are populations who are on the edge, who need our support. And what you can do, I mean, I know what you can do with New Jersey Reentry. You can come, you know, unless you have a specialty, unless you're certified, it's hard to work in the space, but you can certainly work at any of our any of our reentry sites as a volunteer in a wide swath of areas. So thank you for asking the question, but it's, you know, if COVID showed anything, COVID showed how those, not only in terms of work habits, medical habits, accessibility to healthcare treatment, are all exacerbated or worsened by those without means and those who have historically battled for equity in this nation.
Thanks, Governor. That's so true. I know you mentioned a phone number. We're getting a lot of conversation in the chat for that phone number. If you could just share that again.
Poor Rob Carter, 732-948-5880. Again, 732-948-5880. Rob is our director of operations, but he came out of the addiction community. So we commit literally to get people in. And so, I mean, we do it the same way that Barrett does it or Brian does it on the ground, but getting, most importantly, detox. And then it's either residential treatment or IOP as it's clinically recommended, but we try to do it for extended period of time. I saw in the chat, you know, we just deal with the court-involved population. So it's court involved means almost everything and anything, but there has to be court involvement, whether it's a veteran involved with a military court of justice, whether it's drug court, whether it's, you know, any felony conviction. But that's the population we have the privilege of serving.
All right. Well, I know we're coming to the end of the time. We did launch our evaluation. So if everyone could take a minute to just give us some feedback on today's presentation. Again, I want to thank our panel. Excellent information and resources that are available. I know there were some questions that we were not able to get to within the chat. You feel free to email those to us and we can connect you or send those questions off to our panelists to hopefully get you the answers that you need. There's information that is being shared via email to all of our attendees. It will include information on credits, information on how to get access to a copy of the slides from today, as well as a recording of this presentation. And I know some resources such as the phone number that Governor McGreevy mentioned, as well as some other websites that were mentioned during presentations. And we will try to get all of those included in that email as well, so that you have access to them.
Yeah,
Again-
and can I just ask you if you could post also our New Jersey opioid addiction report on your website? You can just pull that down from our reentry website if you could.
Absolutely. We'll confirm that we have that right link from you, Governor, and from Lacey, and we'll make sure that we share that information as well.
We should give a round of applause for Angela and Matt. You did a great job.
Thank you.
Thank you
Thanks
so
for your
much.
feedback. Appreciate it. And thank you again, all of our panelists. A lot of information, I know, short amount of time, but appreciate that and appreciate our audience, especially those of you. I know we have over 1,200 of you who have still continued to stay on with us past our time today. So I thank you for that. Again, if you could fill out the evaluation, there's information on your screen about the next upcoming webinar. I hope that you can join us for that conversation again. And I thank you all for being with us, and I wish you well. Have a good day and have a good holiday weekend.